Hello, everybody. My name is Alan, and I want to thank you for taking your time to do this online version of our Operation TAILWATCH course. This lecture is about helicopter safety and utilization. It will consist of a PowerPoint presentation, which you're obviously viewing and listening to now, that puts it all together. Following the presentation, you'll be asked to take a short quiz. Once submitted, you will receive 1 hour of CEUs. During this lecture, we will look at the types of patients that will benefit from air medical transport, how to access the aircraft, and what information you will need to provide the flight crew. And above all, know how to function safely when utilizing a helicopter for patient transport, as well as setting up a safe landing zone. Vanderbilt LifeFlight is a comprehensive emergency transport program. It's been in operation since 1984. Our primary focus is patient care and safety. We have had over 25,000, if not more, accident-free missions. We have 8 rotor wing bases and 1 fixed wing base located across Middle and Western Tennessee. We fly over 3,000 transports a year, and we are the first CAMES accredited program in Tennessee. There are many people that make up the LifeFlight staff. They are the flight communicators, pilots, the mechanics, nurses, paramedics, and other support staff. Let's take a look at these individually. So our flight communicators all have pre-hospital experience at or above the EMT basic level prior to joining LifeFlight. Most have many years of EMS field experience. They perform multiple functions such as ambulance dispatch and tracking, Nashville area aircraft coordination, and helipad prioritization, coordinated medical consults with specialty physicians, medical control, or poison control. Vanderbilt Communications is also Nashville MedCom, the regional medical communication center for the Middle Tennessee region, consisting of 13 counties and 26 hospitals. Our pilots are employed by Air Methods Corporation, which is a national company that services many flight services across the nation. The pilots are to be held very high in standards by Air Methods Corporation as well as the FAA. They must have over 2,500 hours of flight time in order to fly, which is also a requirement of Vanderbilt. Most of our pilots have at over 5,000 hours of flight time, which they received in the military. And many others have certifications, including instructor ratings as well. Our mechanics are also employed by Air Methods. They are highly trained in airframes, power plants, and aircraft maintenance. They have many years of experience. Each mechanic is assigned to a specific base, and we also have a maintenance facility at the Smyrna Airport. Our nurses are registered nurses with at least 3 years of critical care experience. They all have at least an EMT basic level licensure, but many are also paramedics and had pre-hospital experience before coming to LifeFlight. They hold multiple certifications, such as Advanced Cardiac Life Support, ACLS, Pediatric Advanced Life Support, PALS, Neonatal Resuscitation Program, NRP, and some type of trauma course, such as Trauma Nurse Core Curriculum, Pre-Hospital Trauma Life Support, or the Transport Nurse Advanced Trauma course. The flight nurses are also required to have specialty certifications, such as a Certified Flight Nurse, CFRN, Certified Critical Care Nurse, which is a CCRN, or Certified Emergency Nurse, which is a CAN. The flight nurses complete a 1-year orientation program. They're able to perform invasive skills, such as chest tubes, surgical airways, pericardiocentesis, and we are able to care for medical and trauma patients of all ages and train alongside Vanderbilt physicians. Paramedics, very much like the nursing requirements, Paramedics need to have 5 years of ALS experience and a busy EMS service. They hold multiple certifications as well, including ACLS, PALS, NRP, pre-hospital trauma program, and they must also have their critical care paramedic certification as well. They too complete the 1-year orientation program and are able to perform the same skills as the nurse. They're able to care for medical and trauma patients of all ages, and they also train alongside the Vanderbilt physicians. We have the ability to have 24/7 access to specialty physicians. What this means is that we can speak with any subspecialty physician that Vanderbilt employs, including pediatric, neonatology, cardiology, pulmonology, endocrinology, toxicology, neurology, OB, and burn, just to name a few. If we have a question out in the field about a patient regarding one of these fields, we can speak with them and get assistance or information about these patients to guide our care. We have online medical control that we can contact 24/7 as well, which typically is the ED or trauma physician at Vanderbilt. We also have direct access to operating rooms and cath labs. So, if we have an unstable patient that has a penetrating injury to the abdomen or thorax, we can request to go straight to the OR, which saves valuable life-saving time for the patient. This is also true with a patient with an ST elevation MI or heart attack, which we can take straight to the cath lab. This bypasses the ER and saves valuable heart muscle. We can also transport balloon pumps, isolettes, and ventricular assist devices. We recognize that LifeFlight's complete team actually extends beyond Vanderbilt's trauma center and the emergency department to include the pre-hospital groups, EMS personnel, 911 dispatch centers, fire service personnel, law enforcement, emergency rooms, and other hospital departments, all working together towards a common goal, providing the best patient care available. We have 8 rotor wing bases. LifeFlight 1 is located in Lebanon. LifeFlight 2 is located in Tullahoma. LifeFlight 3 is located in Clarksville. LifeFlight 4 is in Mount Pleasant. LifeFlight 5 is currently in Murfreesboro. LifeFlight 6 is in Paris. LifeFlight 7 is in Cookeville. And LifeFlight 8 is located in Humboldt. We also have a fixed wing base currently located at BNA International Airport in Nashville. Our coverage area is typically a 100-mile radius around each base, but we do go further as long as fuel allows. Sometimes we can refuel near the referring facility if there is a refueling airport around that area. Of course, with the fixed wing, we can go anywhere in the United States. Our primary area, though, is actually the southeastern US, but we can coordinate any transport anywhere else. All right, so let's take a look at our aircraft. The picture on the bottom is the newest addition to our fleet. We have 2 EC135s, and the picture on the top left is a 145, which we have 3 of. So let's take a look inside the 135 and the 145. Our aircraft, the 135 and 145, have twin engines with an operating speed of approximately 125 knots or around 144 miles per hour. We can transport 2 patients simultaneously. We have the capability to do IFR or VFR flights. IFR basically means instrument flight rules, and VFR is what's termed as visual flight rules. If you've ever flown in an airplane and have flown in the clouds, that is what is referred to as IFR. Otherwise, a clear blue 22 kind of day, that is VFR. We also have autopilot and weather radar on board. We also have night vision goggles. We have an intercom system set up so that we can communicate in flight with each other. We also have a multi-band radio which we can monitor UHF, VHF, 800, and an aviation frequency at the same time. We have an onboard heater and air conditioning system as well as an onboard fluid warmer. So as you can see, there's not much difference between the 135 and the 145. The 145, after our most recent refurbishment, now has a stretcher loading system that replaces the previous sliding PLS system that some of you may have seen. So again, independent stretcher in both the 145 and the 145, 135. All right, let's take a look inside the 135. So it's a lot like the 145, but the ceiling in the interior is smaller and towards the rear of the aircraft. We carry the same equipment in both. One major difference in this aircraft is the tail boom sits lower, so when loading patients, make sure to lower your head as to not strike it on the tail boom. Also, the exhaust from the engines sit lower, so you will feel the heat coming off the exhaust when loading the patient. The tail rotor is enclosed in this aircraft where it is not on the 145. So again, the 145 actually has an exposed tail rotor, and the 135 has a fan-looking kind of rotor. Again, this is kind of another picture of the 135. All right, so this diagram shows the proper way of approaching the aircraft. Always approach the aircraft from the front unless told to approach differently by the flight crew. Basically, never approach an aircraft from an upslope, always from a level ground or downslope. So again, downslope meaning that you would actually be walking uphill, okay? Never go behind the pilot when loading the patient. Basically, our pilots will get out and they will do what's called a tail guard and just make sure that nobody steps across the rear horizontal stabilizer. Always be aware of the rotor blades. Always, always, always. This is another diagram on how to approach the aircraft. Notice the red area where you should not approach and never go behind the aircraft. Again, never go behind the aircraft. Always approach kind of from the front, basically at a 3 o'clock, 9 o'clock position. All right, so here's a picture of two different aircraft landing at the skyport at Vanderbilt at the same time. So I want you to take a moment right now, take a good look at them, and notice the differences. All right. Do you see the difference in the tail rotor? The 135 has that enclosed fan-looking one, and the 145 has the exposed tail rotor. So the 145 is kind of on that outer pad. The ECI30 is not shown in this picture, but we're going to cover that here in a moment. All right, so let's take a look at the 130. So the 130 basically is not IFR, is VFR only. However, we can still operate any time of the day, and we also have NVGs. It too has that fan-looking tail. It's called a fenestron. It is a single-engine aircraft, and the cruise speed is anywhere from 138 to 150 miles per hour. In the aircraft, we fly with one pilot and two flight crew members. We have a total of 4 seats. So if we do have a smaller patient, pediatric, for example, we can sometimes take a parent depending on the situation. we cannot do 2-patient scene calls in this aircraft. So in other words, we cannot transport 2 patients at the same time. So let's take a look inside the 130. This is a picture of the cockpit that the pilot will be looking at. And this is a side view from the right side of the aircraft, so you can kind of see the seats at the very back wall there. You can see the stretcher where the patient would lie, and the pilot, basically kind of the pilot is more right beside the patient with like a plexiglass partition there. So the biggest difference is with the 130. If a pilot needs to assist with patient loading, the aircraft must be shut down, unlike our 135 and 145, where some of you may have seen the aircraft still running with the pilot outside doing the tail guard at the back. We cannot do that with our 130. The pilots must shut it down. So the startup on the 130 is a lot quicker because, well, why? There's only one engine instead of 2 engines. So it typically can start up anywhere from like 2 to 3 minutes. As I previously stated, we can only do 1 patient at a time. And the main rotor blades on this one are also lower. So you do not approach this aircraft from a 12 o'clock position, meaning right off the nose. You must approach the aircraft from a 9 o'clock or a 3 o'clock position, preferably 3 o'clock because that's going to be the side where we're going to be loading the patient anyways. And again, never approach the aircraft without first making eye contact with the pilot, and he will either wave you in or he will tell you to stop. So always, always, always get the attention of the pilot or the flight crew before entering a running rotor disc. All right, some more differences. Side loading only. So again, what does this mean? We're loading the patient from the right side of the aircraft. Always approach from the right side, never from the front, as I just stated a few moments ago. And this aircraft also does not have IFR. So this picture, a lot of red and green. However, in it, there's a diagram of the aircraft, the 130. And basically, the red is really where you shouldn't approach. The green area is about the only spot. So again, 3 o'clock is the best position to approach it from. If you did have to approach it from the left side of the aircraft, you would need to walk straight into the aircraft and basically hug the aircraft as you're walking around the nose and to the right. But again, you will likely have the flight crew with you and they will escort you. So again, this aircraft, right side approaching. There's a couple other differences with the aircraft. So it's got this stretcher that actually is able to move in all kind of directions. Allows us to kind of access all parts of the patient, which is great. And makes it really easy for loading. There's no chance of like hitting your head on a tail boom with this aircraft. So that's great. And you're not going to get an exhaust downwash from this aircraft. All right, so again, as I previously stated, be careful of the front of this aircraft because the rotors will dip down low at the front. Here's an example. These were a couple of our flight nurses, and one is about 6'2", so not a lot of difference. If there's ever any kind of windy day, there's a potential that some downdraft could actually flex those blades, and that would be a bad outcome to whomever is standing underneath it. All right, let's talk about our airplane. So we have a fixed wing aircraft, which is called a PC-12, Pilatus PC-12, which has a single engine turboprop with an operating speed of 270 knots, which is approximately 311 miles per hour. It's capable of transporting patients across the US, and we do have access to a jet as well if needed, where we have actually chartered a bigger plane for special circumstances. Here's a picture of our fixed-wing aircraft just loading into one of our ambulances. Another picture of the Pilatus PC-12. This is a picture of the inside of the aircraft. You can see where the stretcher is, and a picture of the front. All right, so who benefits from LifeFlight transport? So there are many subcategories of patients on this slide, but the truth is every patient benefits from LifeFlight transport. There are a couple of patients that we do not transport by air. We do not transport any patient with active CPR in progress or imminent delivery of OB patients. But we do have the ability to assist you on scene if needed and transport by ground, or in the event of CPR and return of pulse, we can then transport by air. So the reason for not transporting anyone with active CPR is because we need to do what is in the best interest of the patient, and doing compressions in the back of an aircraft is not optimal because of the limited amount of space and not being able to get right on top of the patient to complete optimal compressions. We also only have 2 providers in the back, where if we transported to the nearest hospital with a ground unit, then we would not only have more space, but we also have more hands working to treat the patient. So there's one exception to that rule, and that is with pediatric patients. If there is a pediatric trauma arrest, we will actually go ahead and fly those patients because, again, they are smaller patients and we have more room, and it's also easier to get effective compressions. So that is one exception to our rule, and special circumstance. So again, we have our trauma patients, our medical patients, cardiac, neuro, OB, the pediatric. All right, so let's talk about trauma patients for a couple moments. So death typically occurs in trauma patients in one of 3 ways. Either immediately, which the patients are usually DOA on the scene. They typically die from a massive head injury or a great vessel injury. The second way is within a few hours, which is why we try to get patients to definitive care within the hour, which is where the golden hour came from. The third way is within days or weeks after the accident. So the golden hour, which is the first hour or hours after the incident, are the most critical. The sooner the patient enters the trauma system, the better their chances of survival. And these patients are dying from rising ICP, blood loss, and hypoxia. These are the patients that benefit most from LifeFlight transport. These are the patients that we are able to treat with initial interventions that prolong their lives until they can get to definitive care or surgical intervention. Remember that LifeFlight brings level 1 trauma care to your scene. The longer the patient goes without definitive care, the worse their outcome. All right, so most of these patients die from sepsis or multiple system organ failure. Research studies show that the earlier patients receive specialty care and aggressive resuscitation, the less the chance of death or suffering from sepsis or multiple system organ failure. So when deciding what patients should we fly, we look at 3 criteria: mechanism of injury, physiological criteria, and anatomical criteria. When we look at mechanism of injury, we're looking at what forces were involved in the incident. It gives us clues on how or even where the patient might be injured. Mechanisms of injury that would clue you into flying the patient are an entrapped patient, ejection from the vehicle, any fall over 20 feet, a penetrating injury to the head or torso, or any associated death within the same vehicle. Note that the two greatest predictors of potentially serious injury are entrapment and ejection. Of course, when you're trying to decide if you want to fly the patient in regards to mechanism, you should also look at the patient's physiological response or anatomical injury as well. For example, if you had a patient who fell 25 feet from a tree and is neurologically intact, no LOC, normal vital signs, but complaining of back pain, this patient probably would not meet the criteria for air medical transport. But if you take the same patient who either has abnormal vital signs, signs and symptoms of shock, decreased neural status, including a prolonged decreased LOC, or numbness, tingling, or paralysis in his extremities, then that patient definitely would meet the criteria for patient transport. Another great example for mechanisms, say you have an entrapped patient, but they're awake and they're talking to you, and maybe they're saying their lower leg hurts, but you can't see that lower leg yet, then you get them extricated and they only have a scratch. That patient probably does not need to fly. However, same patient, again, entrapped, not talking to you, you can't feel strong radial pulses, maybe a weak carotid, that patient you would want to fly. So we can also facilitate extrication with the use of medications. When we use medications to facilitate extricating your patients from the vehicle to decrease their pain during extrication, we can look at this vehicle, as you see in front of you, and you can see there's major front end damage to this truck. This patient could have suffered chest, abdomen, pelvis, or even head injuries. He probably suffered long bone injuries as well. This picture just shows you a closer view inside the cab of the same truck. Note how much intrusion is in the patient's compartment. The steering wheel is also bent, and the airbag has been deployed. Looking at specific damage, this will give you clues on how much force the patient may have actually been exposed to. So, physiological criteria. As we mentioned before, we also look at the physiological criteria when deciding if a patient needs to be transported by air. Air transport should be considered for any compromise to a patient's airway, breathing, circulation, or neurological status. A compromised airway, altered mental status, or signs and symptoms of shock should be such as low blood pressure or fast heart rate, and those can be considered for air medical transport. Now, with geriatric trauma, just be aware that they decompensate quickly because they typically have a very low reserve. Anyone over the age of 65 is typically a level 1 trauma. They also take blood thinners. When dealing with pediatric trauma, note they compensate really well until they decompensate. Meaning that once they begin to decompensate and show you that they are very sick, they will do so very quickly, and then we're way behind in resuscitation. The key is to be alert to their sometimes subtle signs and treat them early. Hypothermia in a trauma patient increases mortality. Be very aware of the environmental temperature outside and use active rewarming measures such as warm blankets and fluids. Crank up the heat inside your ambulance to combat hypothermia, because hypothermia makes the body work harder to compensate, and this can decrease the body's ability to clot and increases acidosis. Also, with winter, this is very important to remember. So, anatomical criteria. Let's talk about this. If you have a patient that has been paralyzed or has some type of neurodeficit following trauma, then this patient is a definite candidate for transport. LifeFlight carries some steroids. And when treatment needs to be initiated, we can actually initiate treatment a lot sooner. When talking about multiple orthopedic injuries, we must note that one can lose a large amount of blood in regards to large bone and pelvis injuries. Watch for signs of shock in these cases. LifeFlight does carry blood and can infuse blood products in these cases. Amputations are candidates for air transport because the faster we can get them to definitive care, the better their chances of reimplantation. When dealing with burns, you should treat them per your local protocols. Keep in mind, though, airway burns, you may want to call for LifeFlight to manage the patient sooner than later because people with airway burns tend to decompensate quickly without warning due to their inhalation injuries. Cardiac patients have garnered attention nationwide for many years. We're trying to get patients to the cath lab as soon as possible to decrease the amount of heart muscle death. The nationwide standard is to get patients from door to balloon in 90 minutes. At Vanderbilt, we have an STMI protocol or STEMI protocol. These are the patients that have active dying heart muscle. Our goal is to get these patients to the cath lab within 90 minutes of onset of symptoms. Ground crews play a very big role in this goal. By calling for air medical transport on the scene, this dramatically drops the time it takes to get these patients to the cath lab. One of the advantages of using LifeFlight for these transports is that we have the ability to take the patients straight to the cath lab, bypassing the emergency rooms, thereby reducing potential heart muscle damage. We also have the capability to complete 12 leads to determine if the patient is having an STMI. If you're ever interested, there are actually cath lab observation times available. I'll take a moment for you to review this slide, and if you have need any more information, just copy down the information on this slide, and you can request more information. Stroke patients. Like cardiac patients, stroke patients benefit from rapid transport to a tertiary care center. Just like time is heart muscle, time is brain. The longer a patient goes with the blockage, the more brain that will start to die off. The main piece of information needed from the ground crew is when symptoms exactly started. So this is a major deciding factor if the patient is a candidate for clot busting medications. Typically, the patients have anywhere from a 3-hour window to a 6-hour window to get these started. The main point to bring out is to find out when the symptoms initially started so the patient may be a candidate for thrombolytic therapy. Without that time, they are not a candidate for this therapy. So, do your best. If there are any family members or bystanders or anyone around that can identify when the last time that person was seen normal, that would be of great benefit. Unfortunately, if it's one of those, a wife found her husband to not wake up in the morning, but she knows that he last went to the bathroom at, say, 11 p.m., then the last time that patient was seen normal was 11 p.m. So these can be tricky situations, but again, if you can get that information, that helps us out so much. Pediatric patients. Pediatric patients decompensate rapidly. The ability to definitively manage the patient is a must. Expert skills, special equipment, strong medical control, and direct access to specialty care are needed. Research has demonstrated pediatric patients have better outcomes when transported by specially trained crews such as LifeFlight and managed in tertiary care centers such as the Vanderbilt Children's Hospital. LifeFlight crews train at the Children's Hospital to treat children and have the ability to contact pediatric specialists for medical control in case questions arise at any time. Neonatal transports. So, neonatal patients require a variety of specialized interventions and equipment. LifeFlight sends a specialty team consisting of a flight nurse, a NICU nurse, and a neonatal nurse practitioner on these specialty transports, but can also send the regular flight crews when needed. Special equipment such as a transport isolate and neonatal resuscitation equipment are included with this team. So, how do you access LifeFlight? You can contact LifeFlight through Vanderbilt FlightCom at 1-800-288-8111 or 615-322-3211. Now, the 800 number is actually for our centralized dispatch, and the 615 number will actually put you to basically Vanderbilt Communications, but that is not for flight requests. That is just for general information. In the past, we used to have some yellow phones, but LifeFlight has also, again, started installing these yellow phones in many dispatch centers and hospitals so that all you have to do is pick up the phone and it will ring directly to the FlightCom without having to dial the phone. So we have a new way to make a request. We've recently added a new tool to be able to request an aircraft. The LifeFlight app allows a requester to initiate a request. And on this app, it basically will ask you for your information, where you are, and we'll immediately put that through to our Aircom that starts generating the flight. Here's just a slide about our LifeFlight app. If you want to pause and take a moment to look at it, I will let you do that. So LifeFlight launches upon your request. If you think you may need an aircraft, but you are not quite sure, you can place us on standby. We have two different kinds of standbys available. One is called a flying standby, and then there is a standard standby. We are called for flying standbys typically in counties that we have extended ETAs to, or to counties that have limited resources or no hospitals. When on a flying standby, we will treat it almost like an actual flight, where we will lift off and go towards the scene, and we will remain 5 miles from that scene until you decide if we are needed or not. If you need us, we will continue on to the scene. If you decide you do not need us, then we will go back to our base. There's no charge to the patient nor the referring agency when this happens. With a standard standby, we will gather our equipment, get the aircraft out of the hangar, and make sure everything is ready for the flight. Once you decide that you need us, all we have to do is get in the helicopter and lift off. All right, so flight times, of course, depend on where we are going. Just know that when Aircom gives you an ETA, it is a total ETA, which includes our liftoff time, which varies from aircraft. So an ECI30 might have a 6-minute on average liftoff time. The 135 may have 8-minute average liftoff time, and our 145 will have an average 10-minute liftoff time. Once the aircraft is in the air, Aircom will call your dispatch and let you know an updated ETA. So once we are going, they'll say, hey, be advised, LifeFlight's ETA to you is now 15 minutes. Let's now look at the information that will be needed by Aircom. Please note that as this information is being gathered by Aircom, an aircraft is being simultaneously dispatched. The primary information needed are, of course, who you are, the nature of the incident, location by state, county, street, address, and or cross streets for scene requests, hospital name for inter-facility requests. Coordinates are helpful, but Aircom will verify coordinates with the street/cross street. Ground contact, LZ, so who's going to be our LZ command, and radio frequency that we'll be using. An approximate patient weight is important, and patient weight helps the pilot plan weight and balance for the aircraft, as well as assisting the medical crew with planning for treatment. A brief patient report with nature of illness/injury, patient's age, gender, and vital signs is kind of a bonus, but not something that we typically look for. We're more concerned about our LZ landing spot and the safety with it. So if there's time for a patient report, we'll take it, but otherwise know that that's not a priority. We would rather get information on where we're landing. So other helpful information that is needed is, are there multiple aircraft needed and number of patients? LifeFlight has the capability of transporting 2 patients simultaneously in our 135 and our 145 aircraft. And our 130, of course, we can only carry 1 patient. So we can send additional aircraft if needed. We also need to know if another aircraft service has been called or is responding into the area. And this information is for safety purposes, and we need to know this information so that we are aware of other aircraft in the area, and we will communicate with the other service and work with them in regards to the ETAs, the landing zones, triage, and other things. This will make sure that there are no safety mishaps or mid-air collisions. Adult or pediatric? What type of patient is it? This allows us to know which equipment to have ready. Are they entrapped or being extricated? If it's going to be a prolonged extrication, then we will most likely shut down the aircraft to decrease the amount of activity or noise on the scene, which will increase the safety margin for everyone. What's their neural and respiratory status? This will let us know if we need to have our airway kits out and ready to intubate. So weather check. If the weather is questionable, then we will be on what we call weather checks, which means if you request us, Aircom will have to call the pilot first to complete a weather check. The pilot will obtain current and forecasted conditions for the area before making the decision whether or not to fly. The pilot has the immediate access to this information, so there is really little delay. All right, so as kind of talked about before, VFR is visual flight rules. This means we're able to see as far as we need to and fly as high as we need to according to minimum standards. IFR is instrument flight rules. This means that the pilot has to fly with instruments due to not being able to see or fly as high as the minimum standards. So when visibility and the cloud ceiling is below regulated minimums, the pilot will have to fly IFR. When this happens, the pilot will have to get a flight plan from flight services to the closest airport near you. This will result in a delay for us to get to you because we have to follow a specific flight plan, which is not necessarily a direct line. We do not fly IFR when there's icing conditions, thunderstorms, or lightning. The number one cause of EMS helicopter crashes involves marginal or poor weather. Vanderbilt LifeFlight strictly adheres to weather minimums and has flown, as previously stated, over 25,000 accident-free transports. Just because the weather is good at the LZ does not mean that we can get there. It may not be good where we are or even in between. So, let's talk about landing zones. There should be one person in control of the landing zone, which is the landing zone officer. The LZ officer should use pre-existing landing zones or PELA sites whenever possible. LifeFlight will land wherever you need us to as long as it meets certain criteria, which we will cover later. The LZ officer should be the only person communicating directly with the flight crew prior to landing. The airways should remain clear or traffic when we are final landing, so we may hear if someone should point out a hazard that may be in our path that we did not see, such as wires. The LZ officer should assist the pilot with simple directions and landmarks to locate the LZ. This is usually easily completed by using the directions of the clock in regards to the aircraft. So, looking at the aircraft from the top down, 12 o'clock is the front of the aircraft and 6 o'clock is the back. So when you get a visual on the aircraft, you should state, LifeFlight, we have a visual on you. We are at your 3 o'clock. This will let us know to look at our 3 o'clock and we should see the LZ. It's very difficult, especially during the day, to see where the LZ is from the air. The LZ officer should mark and locate all obstructions, which we will go over in more detail later. Next, you'll see a short LZ setup and communication. All right, so our LZ, basically what we're looking for, we need a flat and firm surface. It should be about 100 by 100, which is basically about the size of a baseball field. It should be clear of obstructions or hazards such as wires, poles, trees, signs, antennas, loose debris, gravel, sand, dust, snow, long grass, etc. Some LZ hazards include the trees and poles, power lines, loose material, uneven terrain, loose dirt or gravel, and high grass, as I just stated again. The number one LZ hazard are wires and utility poles, which is because they are so difficult to see from the air. Prior to landing, LifeFlight will always complete a 360 high recon of the area to visualize all the hazards that hopefully you have marked or pointed out. And I will say, if you see wires, best thing to do is to park your vehicle underneath those wires, and you can point that out to us. When describing hazards, use north, south, east, and west directions. Helps us out a lot. All right, looking at the picture on the left just goes to show you how difficult it may be to see a landing zone on the ground from the air, especially during the day. See if you can point out the LZ in the picture on the left. The pictures on the right are pointing out how difficult wires are to see as well. Wires are the number one hazard for us because they are so difficult to see from the air. When you're looking for wires on the ground, you have the backdrop of the sky. So there is some contrast, which makes them easier to see. When looking at them from the air, we don't have the backdrop, so there's usually no contrast, and they blend in, which makes them very hard to see. We really depend on the ground crews, you, to mark those wires and communicate that those wires are there to the flight crews prior to landing. When marking wires and power lines, again, Place a lighted apparatus parallel under the wires if your resources allow you. All right, take a look at the two pictures here. This was an actual landing zone. Can you make out the power lines? I'm going to highlight them here in just a second for you to see. Take a moment, review. Do you spot all the power lines? All right. If you saw those, great. It should be easier from the ground, and it would really help us by parking your vehicles under those. All right, going back to this slide. Sorry about that. Basically, with slope limitations is you can get into a situation of what is called dynamic rollover. So that is why we need a flat surface. Okay, let's talk about LZ officer responsibilities. So the LZ officer will locate the 100 by 100 foot unobstructed level landing zone as close to the patient as possible. If appropriate, and if resources allow, place the personnel or vehicles at each corner of the landing zone. If you have time, you can wet down loose gravel or sand and pack down any snow. Make sure to direct any auxiliary lighting to the ground as to not temporarily blind the pilot or medical crew. This makes sure, and also make sure never to direct any lighting at the helicopter when it's in operation. Note this diagram of the landing zone. Notice that it is 100 feet by 100 feet in diameter. Also note there are markers on each of the four corners of the landing zone marking where you would like the helicopter to land. If you can find out the direction of the wind, then you can be aware of which direction we will land, because we will most likely land into the wind. So be aware if there are maybe antennas or high-level trees in the path that we will be coming in for landing when selecting an appropriate landing zone. Let's talk about some things that we should not do in regards to landing zones. Flares can be a potential fire hazard and therefore are not appropriate to use to mark a landing zone. Traffic cones tend to blow away upon landing, so don't use them unless you can secure them to the ground. Make sure everything is secure. If you think it could be blown away, then it should be secured. No one and no vehicle should be in the 100 by 100 area unless told to do so by the flight crew. No one should be smoking anywhere near the landing zone due to fire hazards from the fuel of the aircraft and the oxygen on board. And the landing zone should remain secure until the aircraft has safely lifted off. Police at the LZ. We would like there to be a police presence at the landing zone whenever one of the following occurs. If it's domestic violence, gang-related, if there's any violent offense such as assault or penetrating injuries, a prisoner transport, uncontrolled scenes such as unruly family or bystanders, or suspected child abuse. These events have the potential to affect the safety of both flight and ground crews alike and can typically be prevented when there is a police presence there to control it. One other aspect of security is to make sure that all patients are checked for weapons prior to flight. Again, check all patients prior to flight for any kind of weapons such as guns or knives. It is a federal regulation that no weapons are carried on the aircraft, so we want to make sure that this is checked prior to the patient being placed on the aircraft. Again, if they have pants on, check their pockets. So LifeFlight will contact the LZ officer approximately 5 to 10 minutes out. At this point, we'll ask for a brief description. The LZ officer will identify any hazards, communicate them to LifeFlight using north, south, east, and west directions. The flight crew will ask for a brief patient report if the EMS crew is able to communicate that information. And the flight crew will ask the LZ officer to contact them when the visual contact is made. So once you have a visual on the aircraft, then let the flight crew know using that clock direction, noting again that 12 o'clock is the front of the aircraft, 6 is the rear. So again, LifeFlight, we have a visual on you. We're at your 3 o'clock. Also note that LifeFlight does not use 10 codes, so try to use plain English, as 10 codes differ from county to county, so to make it difficult to understand. An LZ officer will move to the periphery of the landing zone when the aircraft is coming in for its final landing. Also note that LifeFlight does not require a charged line to land. The chances of a fire is very minimal. All right, perimeter guards. So, this is a policy that was adopted by LifeFlight in 2008. This gives us an added security measure at the LZ to keep people and vehicles away from the aircraft. It gives us an added set of eyes when resources allow us to do so. When the flight crew contacts the LZ officer en route to the LZ, they will request the LZ officer to assign someone to be perimeter guard. Once on the ground, the flight crew will brief the perimeter guard on what the expectations of their duties will be. For example, I need you to stand here and make sure that nobody approaches this aircraft from all directions. If you happen to be on a highway, we may want one at the front end. So the perimeter guard is typically 50 feet in front of the aircraft, in direct view of the pilot. It can be 1 or 2 people, depending on resources. The pilot, once the aircraft is in idle position, will be at the rear of the aircraft in the 130 and 145 aircraft only. The 130 does not shut down. The pilot does not get out of that. And he'll go to the rear. Since this will be the case, the perimeter guard will need to offset themselves to the left or the right in order to have direct line of sight with the pilot. So again, if you see the pilot get out with the engines running, make sure you can keep an eye on them. We don't want the perimeter guard going towards the aircraft, either nor tackling anyone who's trying to do the same to go near the aircraft. Instead, attempt to get their attention, like the pilot's attention, either by radio flashlight yelling or last resort by getting the pilot's attention and let the pilot intercept the person or the vehicle. The perimeter guard will go to the position in front of the aircraft after the aircraft has landed and leave the landing zone after told to do so by the flight crew or when you hear the engines starting to get louder for liftoff. Final approach. On final approach, the pilot and crew will observe for wind direction, speed, and any unexpected obstacles. Upon landing, notify your dispatch. Please note the flight crew will come to you. Again, flight crew comes to you. Refrain from any unnecessary radio traffic during landing. No one should be in the 100 by 100 area. Never approach the aircraft. This diagram is noted how the perimeter guard should be in front of the aircraft, at least 50 feet. In those positions, they can actually see the pilot if he gets out of the aircraft. Keep the LZ secure. Make sure to keep the patient in the ambulance. Let the flight crew come to you. Again, don't start bringing the patient to the aircraft just because we like to get an assessment of the patient in an ambulance in a controlled environment. As the aircraft is noisy, dark, and we need to be aware of any change in the patient condition. The main rotor wash may also be strong, so make sure that if you are asked to help load a patient, that you keep your helmet down, secure your chin straps, and secure any loose items. In the event of a forced or hard landing, the chance of fire is very minimal in our aircraft. Only approach the aircraft after the blades have come to a complete stop, and do it with care. If something like that were to happen, obviously notify your dispatch. immediately of the situation. All right, so general aircraft safety. This is one of the most important items we will cover during this presentation. Beware of the tail rotor. Do not step behind the aircraft. Never approach the aircraft unless told to do so by the flight crew. Rotor blades striking ground crews will result in death. The next couple of slides show the result of a tail rotor strike, which happened on an aircraft carrier. Note that the next couple of slides are very detailed and are not intended for the fate of heart. On that note, if you have a squeamish stomach, I will allow you to turn your head so you don't have to see these pictures. This gentleman was wearing a helmet much like the helmets we wear. As you can see, the helmet was no match for the tail rotor. The main thing to take home is to have situational awareness of the rotor blades. Listen to the flight crew and never approach the helicopter unless told to do so by the flight crew. Together, we can make sure that everyone stays safe. Okay, for those of you who turned your heads, you can turn your heads back. Once again, beware of the rotor blades. I cannot put enough emphasis on how important this is. Approach and depart the aircraft from the same direction. Carry the patient and equipment carefully. Never carry anything above your head, which also means put your IV poles down. The pilot will maintain tail watch duty on the 130 and 140, on the 135, 135 aircraft. Never go behind the pilot. Again, if you're using a stretcher, make sure that the stretcher does not come in contact with the bottom of the aircraft as to not accidentally punch a hole in the aircraft. Again, IV poles are down. Allow the flight crew to secure the Bucher stretcher inside the aircraft and operate the doors since they have been trained on such equipment. Again, let us do all the doors and the stretcher. Here's a picture of taking the patient to the aircraft. Note that everything looks secure. There are no hats on and all equipment seems secure. There's nothing above the head level. This picture is also loading the patient. Patient is loaded head first on the 135, 145 aircraft. No one has gone. You'll see that the pilot is there acting as the tail guard. No one has gone behind him. By the way, is this a secure landing zone? Take a moment, take a look at the picture. If you answered no, it's not secured, you're correct. There is a dog in the background. Also, he does not look to be bothering anyone at this time, but you can never tell. So it's probably a good idea to make sure that all animals are secured as well. And also telling by this picture, because the tail rotor looks blurry, it is running. So again, loose dog. Here's another picture of our 130 being loaded. Note that the ground crew is leaving the aircraft the same way they approached it. The pilot is still performing the tail guard. So again, always leave the same way. All right, hazardous materials. If responding to a hazmat incident, let Aircom or the flight crew know what the hazard material is and the placard name, and we can make contact with toxicologists to find out what and look for as far as the signs and symptoms, treatment, and how to properly decontaminate the patient. You must land us at an alternate site away and upwind from the hazardous material site, and decontaminate the patient prior to transport per your local hazmat protocol. Decontaminating the patient includes removing the patient's clothing and leaving the clothing on the scene. Decontamination includes fuels such as gas and diesel, not just chemicals. So again, if your patient is drenched in gasoline, clothes need to come off and they need to be rinsed off, the patient. Let Aircom know as soon as possible, and they will advise the flight crew of any possible concerns. All right, our ground EMS and critical care and event medicine. So we actually had 4 ground ambulances, but we have many more now. And last year we actually added our critical care transport program. So we got 2 of the quad cab Freightliner vehicles. So basically, we provide ground EMS for different events. We also have an ambulance stationed out at our Vanderbilt Wilson Hospital, and we also have our critical care trucks, which basically we have a day truck and a night truck. So our event medicine team covers more than 600 special events a year, and LifeFlight is the official EMS provider for the Nashville Predators, Vanderbilt Athletics, Nashville Sounds, and many others. All right, iFly program. This is something that actually we implemented many years ago, where basically sometimes we will take an EMS person off the scene and allow them to fly with us to the hospital with the patient, just so that they can see the care done in flight and kind of for a few minutes at the hospital. This has to be done with your county's permission, because usually it involves the supervisor having to take over and man your truck while you're gone. So if you're interested, I'll let you pause this video. You can take the information down and contact me for any other further information. Other LifeFlight outreach and educational opportunities. We've offered multiple educational opportunities through our referring agencies, and you can sign up for these by going to our website. And we also, as of right now, we normally have had EMS night out, but that's on hold due to COVID. And we're offering lunchtime learning series. Right now, these are typically a 1-hour class where CEUs are offered, and it's actually every Friday from 11 a.m. till noon. So great opportunity to get some CEUs. And with our Operation TAILWATCH class, obviously we have that. If you are wanting a physical class, typically, it takes just over an hour to do this class, and then we have about 30 minutes where you can kind of take a look at the aircraft and get your hands on and ask questions. So, if a patient needs an advanced level of care and/or rapid transport, call LifeFlight. Remember safety procedures. Remember the LifeFlight difference, which is specialty care and rapid access to definitive. We bring advanced trauma medical care to all patients and populations and provide rapid transport. The LifeFlight nurses are trained and able to provide multiple advanced procedures, including we can do lab values, and we carry blood, and as well as we have direct access to the OR and cath labs, and we have direct 24/7 contact with our online medical control and specialty physicians. And we not only transport to Vanderbilt, but we also transport to other hospitals within our coverage area. And if you have any questions, you can email them to that address right there. And I want to thank you again for taking the time to view and take this course. I highly encourage you to take this as needed, and also recommend telling your colleagues about it. Again, you'll get 1 hour CEUs after you do our quiz. And again, just want to thank you again.